Infection of the bone. So in osteomyelitis, most frequently involved organism is always Staph aureus. Uh, in infants, in children, in adults. Other organisms involved in less than 2 months is group B streptococcus and E. coli. B for baby, and as they always do diarrhea, so E. coli. Group B streptococcus and E. coli less than 2 months, and in 2 months to 4 years they are the king. The children are the king. They tease, they play around, they make a mess of the house. They are the king. Kingela, kinge. In greater than 4 years, as we talked, Staph aureus, and in sickle cell disease, also Staph aureus, but 2 by 3rd of the infection is caused by Salmonella. Now, in other organisms in infants are, as we talked about, group B streptococcus, E. coli. In children we can also have streptococcus pyogenes. In prosthetic devices, staph epidermidis, and in UTI or urinary tract instrumentation, it's UTI wale organisms, that is Klebsiella, or it can be Pseudomonas aeruginosa. Now, if a patient has a nail puncture wound, if he punctures something, then the organism is from P, that is Pseudomonas aeruginosa, in case of nail puncture wound, especially through rubber sole shoe. And the clinical features would be same as osteomyelitis, that is local pain, swelling, warmth, along with systemic inflammatory signs like fever, and on CBC it can be increased leukocytes. Then after CBC, and we will see also ESR, CRP, they can be elevated or they cannot be elevated. Then we will do blood culture. Blood culture may reveal the infective microorganisms, but sometimes we have to do a bone biopsy. And the third thing we do is radiography, that is plain X-ray, and it shows evidence of the disease about after 2 weeks or more. If we want to do it earlier by radiology, we have to do an MRI. So 3 main investigation. One is CBC along with ESR and CRP, and the second is blood culture, and if blood culture is not so revealing, then bone culture, and the third is radiography, plain X-ray in greater than 2 weeks, or MRI. The treatment for Pseudomonas aeruginosa in osteomyelitis is oral or parenteral crinolines and aggressive surgical debridement. Now, as we talked in sickle cell disease, 2/3 Salmonella and 1/3 Staph aureus, so empiric coverage should include both. For Salmonella, we give 3rd generation cephalosporin, that is ceftriaxone, and for Staph aureus, we give anti-staphylococcal therapy, that is oxacillin and vancomycin. Now, diabetic patients can also have osteomyelitis. Osteomyelitis should be suspected in them if it is a long-standing infection that is greater than 1 to 2 weeks, and if we have systemic signs like fever, chills with elevated ESR, and also the local sign, that is the ulcer is large, greater than 2 centimeter, and we can palpate some bone in the ulcer base. So patients with diabetes have osteomyelitis. So what do you think? Which microorganisms? It must be polymicrobial, gram-positive, gram-negative anaerobes. And it is due to contiguous spread from the wound. Treatment would be to remove the wound, that is wound debridement plus IV antibiotics. Which antibiotics do we give in diabetes? Peptars plus vancomycin, because diabetes is so dangerous. We have to give 3. First is peptars and vancomycin. Now we move on to vertebral osteomyelitis. So vertebral osteomyelitis, the features will be the same, that is fever, back pain, and focal spinal tenderness, same. And what investigations I told you? CBC with ESR, CRP, blood cultures, and plain spinal X-ray. If X-ray fail, then ESR and CRP are raised, but normal X-ray, then MRI, and instead of blood culture, we will do a CT guided needle aspiration or biopsy of the bone. Highest risk of osteomyelitis, always remember, in IVDU, IV drug users. Sickle cell anemia also has increased risk, immunocompromised, and recent infection are other risk factors for osteomyelitis. In vertebral, the hallmark is tenderness to gentle percussion over the spinous process of the involved vertebrae. It is the most important clue. Most reliable sign for spinal osteomyelitis is tenderness, most likely due to hematogenous spread of recent infection, example the UTI. Staphylococcus aureus, about 50% of the cases of pyogenic spinal osteomyelitis. Staph aureus is ubiquitous. Other pathogen, including gram-negative, can also cause. Patients often present with back pain, and if they don't have the fever, sometimes which happen in vertebral osteomyelitis, it can be misdiagnosed as degenerative spine disease. And as we talk the clinical features, focal tenderness on percussion of the posterior spinous process, and due to which the surrounding inflammation will lead to muscle spasm and decreased range of motion. Sometimes this osteomyelitis can track inside and reach the space above the epidural layer. So we call it epidural abscess, and it leads to severe back pain with even the nerves involvement, so motor and sensory features are there, and it can even lead to paralysis. In initial work we already did this blood CBC, blood culture, ESR, CRP, and plain X-ray, and leukocyte count may be normal, but ESRs and CRP are usually markedly elevated. In vertebral, remember, fever can be absent, leukocytosis can be absent, but ESRs and CRP are elevated. Plain X-ray can be normal in the first 2 to 3 weeks, so MRI is the modality of choice with patients for suspected vertebral osteomyelitis. And it can also diagnose the complications like epidural abscess and cord compression. Radionuclide bone scanning using gallium is an alternative for patients who cannot undergo MRI. Radionuclide bone scanning using gallium. Computer tomography, guided aspiration and culture of infected intervertebral disc space or bone are needed to confirm the diagnosis. Then,